please switch to the next slide? So today I'm going to be discussing the latest papers, the placebo effects and neuromodulation for depression, a meta-analysis and evaluation of shared mechanisms. This was published in Molecular Psychiatry back in December 2021. So for multiple reasons, I wish to discuss this paper. So I think, first of all, it's very broad and ambitious scope. It's very creatively done. There's clear kind of clinical significance for me. And I think it also helps us explore, what is the power of the mind and how can we understand that from a neuropsychiatric perspective. So next slide, please, Matt. And just a brief outline here of what we'll be discussing over the next 15 minutes before we move on to the expert panel's input. Okay, next slide. Okay, so placebo can be considered an inactive substance or procedure that looks like a drug or the treatment being tested. So you could think about a sugar pill, injections of saline, or machines that look like they'll be helpful. So placebo was kind of first discovered back in the 18th century by John Haygarth, who was an English physician, and he did the first placebo-controlled trial. At that point, he was testing for therapeutic claims that metallic attractors could draw out disease in some form, and he conducted a trial that showed actually wooden ones were just as effective. And over the last 3 centuries, really it's formed part of a gold standard, so a sham-controlled RCT. The traditional view would be that this would allow us to compare results between 2 groups and tell us which test group were getting results from the treatment and which just occurred by chance. So possibly placebos are the most studied intervention that we know about because of the placebo-controlled trials, but unfortunately, they're very poorly understood. And there's some underlying therapeutic possible psychological principles, so components including positive expectation, motivation, and anxiolysis are common to multiple different placebo types. Okay, and next slide, please. And just a brief introduction. So neuromodulation is can be done with technologies such as deep brain stimulation or transcranial magnetic stimulation, which is shown here in the image. And they've been one of the most promising sort of recent advances in the management of medication-resistant depression. So TMS is a non-invasive means of focally stimulating the brain via electromagnetic induction. TMS is a safe procedure and has been licensed in the US under the FDA for treatment-resistant depression. However, recent TMS trials have kind of failed to significantly distinguish TMS from placebo, and despite large effect sizes, there's also been large placebo effect sizes as well. Next slide, please. So the authors of this paper had several aims. They aim to create a brain map of placebo effects by synthesizing neuroimaging data from healthy subject and patient subjects of placebo effects in a systematic review. They also aim to then use the results of this meta-analysis to compare areas of the brain implicated in neuromodulatory targets for depression using TMS. And they then explored the implications of potential shared mechanisms on measuring efficacy in clinical trials. And finally, the authors aim to explore the hypothesis that if such overlap exists, then stimulating a shared placebo effects target should be effective for a wide spectrum of disorders beyond depression, so other neuropsychiatric disorders as well. And next slide, please. So just briefly touching on the methods. So this flowchart just shows the search strategy for the neuroimaging meta-analysis. So 1,169 articles were identified, of which 34 neuroimaging studies of placebo effects were included. And this was after searching PubMed, Google Scholar for functional MRI and PET neuroimaging studies of placebo effects. Okay, and then Next slide, please. Again, just exploring some more of the methods, just a very superficial overlay of what the authors did. So there was generation of ALE maps, so activation likelihood estimation, which is a robust quantitative method for pooling neuroimaging metadata. And this method yields sort of statistical map that indicates a set of significant voxels while considering the magnitude of the effects, things like the number of the studies and also the number of participants in each study. And the authors did provide a very detailed supplementary method section to show exactly how they did that. They also performed a comparative analysis of placebo and neuromodulation targets for depression. So they aimed to overlap the mapping of both TMS stimulation sites and their findings from the original meta-analysis. And finally, they performed a systematic review of left dorsolateral prefrontal cortex for TMS trials showing benefits in other diseases apart from depression. So they identified 405 studies, 65 of which met the inclusion criteria. Next slide, please. So now just moving on to considering the results very briefly. So firstly, looking at the results from the meta-analysis of the neuroimaging studies. So next slide, please. Okay, so here we should be able to see the so that the meta-analysis was able to identify common regions of brain activation and deactivation across the neuroimaging studies. So this is a brain map of basically showing representations of the sagittal plane, that's labeled A, the axial and coronal planes. 3 activation clusters are shown, so they were identified and they're shown here in red, and 2 deactivation clusters here are shown in blue. So the 3 significant clusters of activation are the left dorsolateral prefrontal cortex, the left subgenual anterior cingulate cortex, and the right rostral anterior cingulate cortex. And then the 2 significant deactivation clusters in blue were the right basal ganglia and the right dorsal anterior cingulate cortex. The next slide, please. So just now moving on to the comparative analysis, so looking at the findings from that meta-analysis and comparing it to known neuromodulatory targets for TMS. So next slide, please. So here we have the map of TMS and DBS targets for depression. And these are the sort of small colored dots, and they're overlaid on the activation clusters we've seen before, which were associated with the placebo effects. So the clusters in kind of bright yellow, orange. So here we see 2 of them. We see the left dorsolateral prefrontal cortex, and we also see the subgenual anterior cingulate cortex cluster. And there is significant overlapping with the known TMS and DBS targets for depression. So essentially, these findings suggest that both the dorsolateral prefrontal cortex and subgenual anterior cingulate cortex are critical nodes, both for neuromodulation and for placebo effects, and that they may actually directly overlap in terms of a shared mechanism. Next slide, please. And finally, we'll review the systematic review of TMS trials targeting just left dorsolateral prefrontal cortex. So next slide, please. So here the authors have identified 65 trials which showed a positive effect of TMS targeting of the dorsolateral prefrontal cortex. And it's shown significant improvements across 29 distinct disorders, so from anorexia to fibromyalgia, panic disorder, Parkinson's disease, and schizophrenia. And the authors really argue here that the evidence of response to stimulation of left dorsolateral prefrontal cortex supports that there might be a mechanism that's not just specific to depression, but could be consistent with the activation of a more non-specific placebo network. And next slide, please. So just to talk a little bit more on some of the key discussion points. So there was quite a lot discussed in this article that I'm sure Dr. Burke can elaborate on really after this presentation, but just to pick up on two. So to explore a bit more about this kind of common placebo network. So that could be conceptualized as a common brain circuit that could be disrupted in multiple brain disorders. So it's possible that a placebo responsiveness of a given condition may actually relate to how closely its pathophysiology would overlap with this common placebo circuit. But the authors, conclude that further research to interrogate the dynamics of this and the implications in neuromodulatory devices is needed. And then the second discussion point, just to focus on here, is in terms of the potential for shared mechanisms that we've kind of described so far could actually impact on the randomized controlled trials findings. So essentially the authors here wanted to describe a hypothetical experiment to kind of illustrate the potential impact to the sham controlled RCTs. So on the next slide, please. So we should say here, so it's figure A, and in green we can see the potential effect of stimulating left dorsolateral prefrontal cortex using TMS, and in blue we can see a placebo effect. So we now know that actually both placebo and TMS can both increase activity of dorsolateral prefrontal cortex. So in this kind of hypothetical scheme, we could consider if the placebo effects here are high, so on the right, actually the dorsolateral prefrontal cortex circuit could become near maximally activated. So it could hit a ceiling of activation, which would then make the subsequent sort of green TMS activation less efficacious. Next slide, please. And here again, so there's just a few more hypothetical clinical trials just to demonstrate the different impact of, in this case, doubling placebo effects when the treatment has a therapeutic mechanism independent of placebo effects. So in the first experiment just on the left, so marked 1, we can see here that the effects are additive. And so we still see a difference, even if placebo's doubled, we still see the effects of the stimulation. However, on the right, in hypothetical experiment 2, this models more of the shared mechanism of placebo effects. And here we can see that the increasing placebo effect effectively limits the ability to detect significant difference between the active and the placebo groups. Next slide, please. Right, so just finally to consider some of the limitations of this study, which were recognized and clearly articulated by the authors. So it's important to point out that the limitations of the placebo effects neuroimaging literature. So 80% of this concerns only healthy subjects, and actually only one study looks specifically at the placebo effects in patients with depression. It's also worth considering, are the changes induced by placebo truly similar to that induced by neuromodulation by TMS? It's also important to note that the comparative analysis, so the combination of the TMS targets with what was found by the meta-analysis of placebo effects, that was purely descriptive. It's not a statistical or quantitative comparison. And as well, I just wondered if there could be some publication bias when considering the systematic review of the treatment efficacy for TMS of the left dorsolateral prefrontal cortex, and whether or not there's some publication bias affecting those results. And next slide, please. Great. And then lastly, just laying out, where the study takes us to and the future directions leading from this. So the authors kind of highlight, they think future neuromodulatory studies should include a third arm, so a no treatment control group, which would be really helpful in kind of understanding the interaction and boundaries between the placebo effect and treatment. They also suggest that we should start evaluating neuromodulation of placebo effects in themselves. So essentially, can we increase or boost placebo effect by stimulating, for example, dorsolateral prefrontal cortex using TMS? So that's kind of unexplored at the moment. They also suggest that we could start using some open hidden paradigms in TMS studies for depression, and that we need to really explore the extent of overlap between placebo effect circuits and other brain network models, for example, the default mode network, and other network models for depression. Great, next slide, please. And I think I'll stop here for my presentation, and we'll invite our expert panel just to perhaps give us 5 minutes of their insights and thoughts about this work and related work. And then we'll move to Q&A. So if people could please start typing questions into the chat, or raise your hands and we'll come to you. Thank you. And maybe we could start with Dr. Burke. That's okay, seeing as you're the lead author. Thank you.
Can you hear me okay?
Yeah.
Excellent. Nicely done, Eddie. That was a really nice review and great choice of paper to kick off the Neuropsychiatry Journal Club. Obviously, I think that, you know, this work was important, and it was a long kind of journey to get to this published. As you saw, there were many different analyses and kind of considerations when it came to the implications of the results. And, you know, I thought you did a really good job synthesizing the paper. I would just emphasize, you know, this work, you know, I was worried that the headline would make, you know, neuromodulation scientists, you know, defensive of, oh, he's saying that it's, you know, placebo effects. That's not the intention of the study at all. The study is showing this potential shared mechanism, which actually the implications would be that it would maybe undermine the ability for TMS and other neuromodulation technologies to be shown efficacious against a placebo sham in an unfair manner, because if there, as Eddie showed, if there is this shared mechanism and that's your comparator group, then if the placebo effects are large, as in the case with many you know, innovative novel studies at prestigious universities, then that might eat away into the effect that you would have seen from your active treatment, the TMS in this regard, that does stimulate that circuit in that region. So, you know, obviously, I think that this leads to a lot of thought-provoking questions for the field about ways to measure efficacy. And certainly this is not just specific to TMS or neuromodulation. This is probably specific, this is probably relevant to all depression treatments or many depression treatments. The reason why we chose neuromodulation was because it allowed for that spatial mapping, because they have specific targets. We could have probably mapped, you know, the density of serotonin receptors in the brain or something, and there is some work by Helen Mayberg looking at the overlap of the brain's response to the placebo and the brain's response to SSRIs. And there is some shared overlap, some differences. And certainly with the growing psychedelic field, there's certainly lots of interest in other complex overlaps that may be happening. So I think this relates to many important questions kind of going forward in the field. So, you know, I don't want to chat too long. I want to give people a chance to ask certain questions. Certainly I can chime in later, but I'll leave it to kind of others to provide some input, and then I can answer questions and then go from there.
Great, thanks so much, Dr. Burke. Did you have any immediate thoughts, Dr. Olson?
Yeah, there were a couple things that popped into my head. So the first question, kind of zooming out, would be like, why is the placebo effect of neuromodulation increasing over time? And we know that the placebo effects of neuromodulation therapies have been like very slowly increasing over time. But why do we get this huge jump for neuromodulation in particular? And so one thing that I was thinking is that neuroscience generally has increased quite a bit in terms of its credibility in that, and I'm wondering whether that component combined with like this growing neuroessentialism, in which people feel like they are their brains, and that experiences are only real if like the specific area can be found in the brain that there's a change. I'm wondering whether this kind of global or this more like cultural context of the increase in credibility of neuroscience, and that would contribute to this kind of these growing placebo effects. And I tried looking at some of the social media responses to this paper, and some people were saying things like, "Oh, this shows that the improvements that you have aren't just in the brain, or it's not just you thinking that you're getting better. It's that there's these actual improvements there." And so I'm wondering whether there's this kind of feedback loop in which papers like this that identify the brain regions potentially responsible would help improve the credibility more, which would boost people's expectations more, and then would get stronger placebo effects from that. And then the second question that I have is that if TMS or neuromodulation generally and sham versions of it both kind of compete to activate the same region, would there be no circumstance in which the placebo group would have stronger effects than the real TMS group? And so I was wondering whether there's even a hypothetical experiment in which you can manipulate some of the contextual factors in the placebo group that for some reason you can't in the true TMS group, and then potentially have, like, say, greater expectations in the placebo control, and then therefore larger placebo effects than the TMS itself.
So I'll just respond to a couple of things that Jay was pointing out there. So for those who don't know Jay, he's a psychologist and researcher in Canada, and he's done a lot of really interesting work trying to design super placebos and all the investigating all these contextual factors which might drive up expectation. And so that's probably some of the focus of that second question. And I think many manipulations like that would be very interesting to see in this context about which factors might be driving expectations and maybe creating a group that maximizes that. Certainly many the field is rich for more placebo-focused work, needless to say, rather than just as a comparator standard group. With respect to the first question, this is something we've looked at a lot, and there's mixed findings with regards to how steep that increase in placebo effect magnitude is over time. Some studies have found it to be significant, others not as much. I would say the one additional variable here is that the blinding strategies for TMS has markedly changed over time. And initially, it was probably very likely that the blinding was not that effective, with having kind of the coil angled off the head rather than an actual sham coil. And obviously, if patients know that the sham is not, that they're not getting stimulation, or they know what group they're in, then they would have lower placebo effects. And then so the trials now are using pretty sophisticated sham devices, so that might be another major kind of explanation for that.
Thank you. Yeah, great questions, Dr. Olson. Could we bring in Dr. Siddiqi? Do you have any responses to those questions in particular? Or?
Yeah, I think some of the points that you raised were really interesting. In particular, what you mentioned about what this means about, first of all, common placebo network and implications for measurement of treatment efficacy. I think that's important because when we talk about a placebo network, right, the networks exist in the brain for a reason. And so there are things that intersect, and they might form something that we might call a depression network or an anxiety network or a placebo network, but that's not why those networks are put there. They're put there for some other reason, and we're going to be able to define them better if we figure out the actual reason they were there. We can characterize it a little bit better. The reason I emphasize that is because when we modulate something, if we find that modulating a network can enhance placebo response, then it's not placebo response anymore, right? Because I think Matt wrote in the first sentence of his paper that placebo effects are defined as beneficial therapeutic effects derived from the context surrounding the administration of the treatment rather than the treatment itself. So if you follow that definition, then enhancing placebo response with a treatment, by definition, is no longer placebo; it's something else. It's enhancing expectation. So if we have a circuit-based target for enhancing expectation, that could be an effective treatment for depression. It makes sense, but I wouldn't call it a placebo anymore. But then the question becomes again what you were mentioning earlier, Eddie, that how do we measure it? We need to think about the right way to measure things. And when we're measuring things as depression, as we say, what is your self-reported experience of depression? That might not be the right way to disentangle the effects on expectation versus the effects on, let's say, negative self-view, or the effects on rumination or things like that. But if we think about how to measure them better, I think we might be able to get there. So one interesting thing about this specific paper is, it emphasizes a peak in the dorsolateral prefrontal cortex that's sort of based on meta-analysis of a bunch of placebo studies. There are over the years, we have found that TMS efficacy actually increases as we move forward away from that peak. That specific spot was an older TMS target, the 5 centimeter target. On the surface projection in the paper, it looks like it's right around the center of all of the TMS trials. But that's sort of an artifact of trying to take a 3-dimensional thing and flattening it in 2 dimensions. In reality, it's just 2 centimeters deep to the original, what we call the 5 centimeter treatment target. So it turns out that over the years, we've found that that's actually separation from placebo gets better as our simulation site gets farther away from that placebo spot, which I thought was interesting too. It'd be interesting to look to see if that works better when you compare placebo-controlled trials and non-placebo-controlled trials.
Yeah, I would say that those are all some really good and interesting and insightful points. It's obviously great getting your input on this, Shan. He's a world leader in understanding kind of targets for neuromodulation, and in particular depression. And so, just to respond to a couple of those points, I completely agree that if we're framing, that TMS might activate this, whatever network you want to call it, placebo network, depression network, whatever, then that is, a specific treatment. The overlap issue becomes with how you measure the efficacy then. And I think that, one other point that we didn't talk about was the fact that there is pretty good evidence for like state dependency of TMS effects. And so if you have someone sitting in that chair with a very positive expectation that they're going to get better, keen, attentive, and getting stimulated, and that that part of the brain is already kind of primed or active, and then you're stimulating that part of the brain or that circuit, there might be synergies there that we don't fully understand yet, versus someone who might be in a hopeless state that does not have positive expectations. That circuit is not kind of primed. So lots of interesting questions with regards to the potential synergies between the state and the treatment. And then absolutely, I think that one of the major limitations of this study is it's pretty a gross overview. We have some clusters, but in reality, there is so many probably subparts to these clusters. And as Shan's saying, there's treatment targets that might be connected in different ways that are further from, the placebo effects cluster, and might, start to separate. I think that would be very interesting. Certainly one of, up until, there's this huge contrast between two of the major recent large TMS RCTs. There was the one that used a non kind of targeted approach in the VA group, with a huge study in JAMA Psychiatry that showed huge placebo responses, like 40% remission rates. There was some other issues with that study as well that people cite. But then the more recent work out of Stanford that uses this target approach, or a targeted approach, showed a pretty marked difference between active and placebo. So maybe it has to do with some of the targeting considerations that Shan's mentioning. Yeah.
Yeah, the Stanford group also worked really hard to minimize their placebo response. Like they gave people lidocaine at the simulation site, so everybody felt numb, and then they told everybody that you should feel numb, you shouldn't really feel it, and they went to a lot of great lengths like that to minimize placebo response, and they did. Their placebo response was lower than most studies.
Mm-hmm. That's interesting.
We just have a question here from the audience. So Robbie Steele has written, so with the widespread acceptance of the double-blind placebo-controlled RCT as the gold standard for therapeutics research, it's a huge challenge to anyone wanting to study the placebo effect itself. So what would a placebo versus sham neuroimaging study look like? Does anyone have any thoughts how we might do that?
I definitely agree. I don't love the idea that double-blind placebo-controlled RCTs are the gold standard for therapeutics. I think that's there are a lot of things that you miss when you do that, and they should be a gold standard, but not necessarily the gold standard. So we learn in medical school that if it's not a placebo-controlled clinical trial, then it's wrong, and that leads us to sometimes jump to false conclusions. But one simple example is a natural experiment with random incidental variance. So when you look at let's say patients who got stimulated at slightly different spots using TMS. Right now, we apply TMS clinically using a very imprecise approach that leads to incidental variation where people get stimulated. When we compare those incidentally variable sites, we find that some sites are more effective than others. In this case, there was no sham group, there was no placebo group. And so we've separated out the effect of a randomized, we've created a randomization without actually applying sham or placebo treatment. So by doing that, if we then add a placebo arm to that, I think we might be able to tackle some of these questions. That does exist. We've done some of these analyses in some of our papers where we separate out the effects of variable stimulation sites from the effects of a sham group. But we haven't done it with this specific intention, which is a good idea. I'll just think more about how to think about it. Well, I'm curious to see what the others think.
Yeah, I would also say it poses a lot of limitations to properly studying placebo effects. One of the biggest unanswered questions about placebo effects is its durability, the durability of the response. And in randomized clinical trials, usually, you're obviously patients who are randomized to the sham group. They usually have to have a limit on the time to which you're going to keep that person in the dark, and then they usually offer the patient the open label active treatment. Not always, but you have a limited time frame to see how that patient would actually do from just placebo over time. And I understand the reason for doing that, but it does limit our ability to really understand the durability of placebo effects. And one of the questions that we posed in the limitation of this paper is, like, let's say hypothetically that we are kind of on the mark that placebo effects are activating a brain region circuit, and the stimulation with these neuromodulation devices are activating a similar circuit. Is it actually the same type of plastic changes that are happening to the brain, or is one more transient than a more sustained kind of neuroplastic effect? These are really important questions to think about.
I just wondered on that, Dr. Burke, how would one start to study those differences? Is it the differences in the actual activation of compared to TMS versus placebo? How would we start to unpick that?
I think that we need to have people like Shan who are sophisticated image scientists and maybe more molecular imaging approaches where we're actually seeing at more high resolution and maybe at a more molecular level almost what changes are being induced. Certainly, there isn't the greatest studies of of what's happening to the brain in a placebo effects condition. That's looking like at a very very fine level rather than kind of a group based standard functional imaging protocol. So I don't know if Shan has any other ideas, but I think the neurophysiology neuroimaging has to get more sophisticated.
I don't think necessarily the neurophysiology and neuroimaging has to get more sophisticated. I think what needs to get more sophisticated is the way that we think about the behavior and how we separate out, again, expectation from clinical improvement and parse out improvement more precisely. For example, measuring it based on a patient's emotional conflict resolution rather than just their self-report depression improvement. And then also designing the study to specifically parse these things out. Like, what is the difference between stimulating an effective site versus an ineffective site, or stimulating an ineffective site versus a sham? I don't think any study has specifically looked at that intentionally, but I think people have incidentally collected this data before. So this point is making me think that we need to analyze that. So Matt, if you're interested in that project.
Yeah, no, many important questions that need further answering here.
We also have another question from the audience. So Dr. Luke Jellin has asked, is there any thoughts on expression of mu opioid receptors in these regions and potential role of modulating antidepressant placebo effects?
It's an interesting thought. Mu opioid receptors are most expressed in the ventral striatum and the thalamus, which didn't pop out in the study. But it just so happens, after I saw this question, I pulled up a map of mu opioid receptor expression. I can show it if I'm allowed. I don't know if I'm allowed to share screen. But it looks like I'm not. Well, long story short, it's mostly in the striatum and in the thalamus. So yeah, it won't let me share screen unless I quit and reopen and log back in. But you can take my word for it if you'd like. That said, that doesn't necessarily mean that the opioid receptor system is not involved. Just because the system doesn't actually have physical receptors there doesn't mean there's no direct link to it. It's worth looking at what's the connectivity between the placebo circuit and the mu opioid circuit, for example.
Yeah, and I'll just say that definitely some of the studies, particularly when looking at placebo analgesia, have definitely implicated the mu opioid system as part of kind of at a neurotransmitter level, the mechanism. There was a nice study published in Neuron that showed that the response could actually be blocked with naloxone. Again, this was like healthy people and a pain paradigm. It's obviously different in a clinical population, looking at depression, for example. But I think it would be very interesting. And again, getting that more data at that next level of mechanism, because we're obviously talking at a network at kind of neuroimaging level, but there's obviously these neurotransmitter systems that are underpinning these networks as well.
But sorry about that. Apparently, you let me share. So this is the basal ganglia spot that Matt published, and this roughly is a subgenual cingulate spot that he published. It's right around here. So and these colors are a map of mu opioid expression according to PET studies. So red is more mu opioids, blue is a little bit transparent, is practically zero. There's a little bit of overlap. There is some connectivity here, so it's worth looking at. Again, that's another future study if anybody's interested in doing it.
Thank you, Shan. I knew that it wouldn't be a true meeting with you unless a picture of a brain was shown on the screen. So thank you.
I think Matt and I had dinner together recently because we happened to be in the same city, and I did not pull up any brain images.
This is true.
Another area I thought could be worth exploring this morning, I think Dr. Olson's already mentioned it, just in terms of the kind of the new trials in psychedelic research and the kind of particular issues around placebo effect and expectations there. I don't know if you wanted to speak to that at all, Dr. Olson.
Yeah, sure. One of the big challenges that you get in psychedelic research is that the blinding is very challenging, because if you give people a moderate dose of psychedelics, they generally know that they've taken that, and so there's some new work right now trying to like suppress the kind of consciousness effects of the psychedelic, and trying to see whether the improvements that you would experience are from kind of the drug itself, or whether they're from the kind of consciousness changes or the mystical experiences that people often experience from that. And I think that the interesting overlap with placebos is that in psychedelic science for quite a while they've talked about set and setting, so the mindset and the context, and how these can strongly modulate the psychedelic experience. And it's the same kind of language and same kinds of things we've been studying in placebo science, where we talk about these different kind of contextual factors. But the overlap between psychedelics and placebos, there's been very few papers actually trying to look at that. So it's kind of like these two fields have been going in parallel, talking about the same things, and it's just been more recently in the past 5-10 years or so that people have started finding these links between them, and possibly taking some of the stuff that we know from placebo science about trying to maximize the placebo effects or have more effective blinding that may be useful for psychedelic science.
Yeah, and for those of you who don't know, Jay was the first author on that somewhat controversial study about tripping on nothing, where he recreated the psychedelic experience without the psychedelic, and showed benefits and whatnot. So there's a whole host of, I think, important questions about we kind of touch on what really matters, right? What really matters to our patients. Obviously, our goals are to improve our patients' lives and symptoms. And if we generate some of that through placebo effects, which is, a brain-based mechanism, and generate some of that through new therapeutics, should we get really upset in a clinical setting? Now, I'm not talking research setting, about where the effect is coming from. If the patients get better, they get better. And so, this gets to more the philosophical realm of things that medicine doesn't usually like to talk about too much.
And I guess there are also perhaps some ethical discussions as well as, what you should be informing and consenting your patients to, and how much that would affect expectation.
Yeah, definitely. And there's ethical concerns on many layers, and this brings the whole and I get myself sometimes in hot water on these recorded things, so I'm going to kind of temper myself a little bit. But there's $1 trillion booming alternative industries that target things like depression and fatigue and pain, and one must wonder how much of the effect that people are getting is through placebo effects, because they are clearly repeat customers and they're benefiting. And is there a bigger problem with that? There's a big price tag sometimes for maybe not too much. There's concerns that you're not maybe treating the core factors that might persist and kind of using having a more superficial effect. But this is very interesting ethical philosophical stuff.
One of the more practical concerns with that as well is also pretty controversial is whether medicine can borrow some contextual factors from these alternative therapies, right? So say if you go and see some alternative practitioner, and it's not just a sterile clinic that you're in. There's scents there's, I don't know, warm stones, there's nice paintings, there's a nice view, and that kind of stuff. And so some of these individual factors we know can help promote the treatment effects. And so should we in medicine be going outside of I guess these normal things that we study and say, well, if these alternative therapies sometimes have these very strong placebo effects, then should we be learning from that if we're just trying to maximize the treatment effects? And so there's probably some room for like some controversial synergies between these two domains.
It can be a tricky day-to-day question also as a clinician. You know, as a psychiatrist, when I have a patient come to me who tells me, you know what, I took blank treatment and it made me so much better, I feel amazing. And I'm pretty confident that the treatment is a placebo, and I believe that the placebo is effective for them. What do I do, right? Most of the time, I'll say something along the lines of, great, if something works for you, keep doing it, in an effort to harness that placebo effect. But on the other hand, if a different patient comes to me and says, I want a treatment, and I, based on their personality traits, based on their prior history, I get the sense that they have a long history of transiently responding to a medication that is not that much better than placebo. For example, every time you give them buspirone, they get better, and you get the impression that if I give this person a placebo, they'll be better for 6 months. They'll come back in 6 months. They'll need a new placebo. Can I give that person a placebo? I can't, because there's only so many placebo-like medications you can give, right? So then we get into an ethical gray area. So I think it's a lot easier when the person is telling me they've got a placebo treatment that's working, and I can just tell them to keep doing it. But when we get into a question where I think this person will be placebo responsive, but I don't want to give them an actual placebo, that gets a little trickier.
Yeah, absolutely. Great points, both Jay and Shan. And yeah, you know, and there's like these, you know, the pure placebos that most people would say you absolutely can't do, like an actual sugar pill. But then there's, you know, the impure placebos where there's not really the greatest evidence, but it's probably not gonna do any harm. You know, oh, here's a vitamin, here's a very low dose XYZ. And needless to say, the ethics of that is still up for debate. But you know, there was a survey of internists in the U.S. saying that the majority of physicians believe that you could prescribe a treatment that you genuinely thought would benefit a patient, even if the mechanism was through expectation alone. I was surprised by that survey result. But you know, I would just say that the one other really big issue when it comes to some of the alternative medicine stuff that we see and translating some of that information is that there's huge harms that can be done when a new unsubstantiated diagnosis is made by maybe somebody in that field, and then the treatment that they're giving is the cure for that unsubstantiated kind of diagnosis, because then the patient might get better through placebo effects, but then they'll be very wedded to this diagnosis that is not, you know, maybe valid or something that we'd all test positive for. And that's a big concern, because then they won't kind of treat concurrently some of the other factors that may be related to their depression or their fatigue, their insomnia, etc. So that's another big concern. But you know, this is all really great, nice discussion that kind of spin off from this important study. I think it just shows that, you know, this is a really interesting topic and we need to study it more.
Another interesting way to avoid some of the ethical quandary, I think, is that it's not very scientific, but something that I learned from my father-in-law, who just so happens to be a small town rural GP in Alabama. I was talking to him about something, and he said, you know, I try to give my patients something when they come in, because it helps with the placebo effect, but he doesn't want to give them something that's useless, so he gives them a flu shot or something like that, something that they would actually benefit from. And that he thinks that everybody should get. And he finds that when he gives people a flu shot, they feel better with whatever it is they came in for. or a flu jab, as you guys probably call it in the UK.
They just want to see your father-in-law. I think it seems like a very interesting guy. That's great.
That's great. So we're coming up just towards the last few minutes of our discussion. So we've obviously had kind of great spin-offs there from all the kind of different aspects around this issue. Just wondering if there's any last questions or thoughts from any of our audience today. Not, then I'd just like to start to wrap up by just thanking our 3 expert panelists. It's been, yeah, really great to have you here. Thank you for taking this time this morning. I know it's early in the morning in North America. And was there any final comments or thoughts from the panel before we wrap up? Great. Okay. So just a shout out, so we've got our next journal club in 1 month's time, so on the Friday the 11th of November, where we'll be looking at autoimmune encephalitis. So keep your eyes peeled for that. And once again, just thank you to Dr. Burke for joining us and for the fantastic research, for Professor Siddiqi and Dr. J. Olson as well. Thank you.
Thanks, Eddie. Great job.
Cheers. See you soon. Thank you.